So ours is a postgraduate teaching department, and about 1 week back we are discussing that in our country large number of medical colleges are coming up. Then 6 AIMS-like institutions are coming up, and there are so many more AIMS-like institutions which are being discussed to bring in some part of the country. But the biggest challenge before us is how to fill up the gap. Excellent building will be there. Excellent, most modern state-of-the-art technology will be available in these 6 AIMS-like institutions or medical colleges, because money is not a problem. But the human resource, from where we'll get that human resource, that is a big challenge for us. So what we discussed, I will share that actually, that how we can fill up that gap. So I hope you must have read this, the Prime Minister's concerns, the wise concern of the quality of medical education in India. The problem is that even the government is aware that we are not able to provide the quality medical education, and something needs to be done. But who has to do that actually? That is a big challenge. Now, I hope you all agree that India marches toward the existing new future of growth and progress. But medical education will play, I am talking from medical education point of view, will play a pivotal role in crafting a sustained development agenda. The effort have to be undertaken to create medical education system that nourishes innovations, that nourishes entrepreneurship, and addresses the skill requirement of the growing economy. Because now large meetings and discussions are being held. I went to US in the month of February, and there actually the first conference which we organized, that is the innovation and entrepreneurship, giving opportunity to the young innovators, to the young entrepreneurs, how to come forward and share what is being done, and then being discussed how to facilitate that the more innovators should come forward. Now, education system is highly heterogeneous and complex with a wide range of, say, providers. So we have a private sector, we have a government sector, but the private sector, we have excellent consultants and faculty resource in the private sector, but they are not being utilized for the medical education as well. The state of medical education in India is more of a wishful thinking rather than building blocks for holistic healthcare. I hope you will agree with this. The medical fraternity is now looking for a need-based curriculum and wishes to shed away the conventional track of traditional and rigid methodology. Recently, I was associated in establishing a medical college in Bhutan, and there we discussed how the traditional, their local tradition system could be included in the part of the curriculum. We studied the curriculum of AIMS and so many other institutions, what are the curriculum being provided by Medical Council of India. Then we had developed a curriculum which is relevant to their country also, not copying what is being taught in AIMS or other institutions, because ultimately this has to be recognized not by the Bhutan Medical Council, but also by the Medical Council of India also. It is often criticized that our medical colleges manufacture students who are not equipped to handle healthcare in its totality, but are mere fixers of the disease. Because we don't give much stress on the prevention and promotional aspects. So a patient comes with some problem, we treat him, and then again keeps on coming for that problem. So we just fix for the time being active, but treating the patient in its totality. Now issues are, the number of medical colleges has mushroomed in last 10 years. I was discussing with the Gyani sir that as on today, the total number of medical colleges in our country is more than 350. And the undergraduate seats have markedly increased without comparable rise in the PG seats. We are having a stress on producing most undergraduate students. Like we say that in AIMS-like institution, we are going to come out with 150 medical students every year. But nobody is talking about the postgraduate medical education. That if there are only 10,000 PG seats like MD, MS and other post-graduate programs, as compared to 34,000 undergraduates passing out every year, and they are desirous of learning PG courses, but what will happen to them actually if there is no opportunities? While graduates generally possess reasonably sound knowledge of medical science, they are generally found deficient in performance of clinical skills and problem solving, which forms the core of clinical competence. So there is a growing trend of mistrust among the public for the medical profession, as one keeps on hearing cases of negligence, the misconduct, and unethical practices leading to legal suits. Now, if we just have a look that we are in India, we have got 6 doctors per 1,000 population as compared to China 14, Brazil 17, UK 21, and US 27. Now, when we talk about the total number of physicians, the annual production of physicians is about 34. So, physician, when I am talking about the undergraduate MBBS students, about 34,000. But the gap is more than 9 lakh. So, how to fill up that gap? This is a big challenge, an issue which needs to be addressed. Moreover, there is a mismatch between the rural and urban healthcare resources. Doctors to population ratio is lower by 6 times in rural area as compared to the urban areas. Now, what are the challenges? First challenge is that there is an information overload. There is a definite overburdening of the students with the content information. So all information is easily available on the internet. So we expect them to visit, come out prepared by tomorrow next class discussion. It could be beneficial to decide and define the core content in categories like what must learn, what is useful to learn, and nice to learn, to prioritize information gathering. Sometimes when we make a presentation or take a lecture, that the main habit is that, okay, this give them a Xerox sets of this presentation, whether they go through this or not. So, no, when we talk about the strategy, I think there is a need for resource pooling, which is very important. IT tools like teleconsultation, video conferencing, or teleeducation. Why can't we have a common digital calendar for participating education institutions? So we have a telemedicine network with, say, 100 institutions across the country. Why can't all those can be clubbed together? We can have a defined digital calendar for coming 2 years. So a lecture being delivered in AIMS, PGI, Chandigarh, or any other good institution or medical in the country, so that every person has a access to that lecture, whether it is a good institution, whether it is a non-medical college. Actually. That type of thing needs to be discussed. And there are some non-traditional ways of learning also, like problem-based learning, on-the-job training, integrated learning modules, learning from other countries, maybe visitors inviting some expert, guest faculties, then learning from private sector, which is how we can bring synergy between the public sector and the private sector. That's a big challenge for us. And introduction of allied subjects like vertical and horizontal integration of subjects like anatomy. A person who is a surgeon, I feel he can teach anatomy, because there is a shortage of teachers in anatomy, physio, biochemistry, and other paraclinical subjects. Why can't one actually can teach the other also how we can utilize their talent for other subjects also, like medicine and pharmacology, so they can teach. But this is not being done. No, we have to enlarge the range of settings in which the educational programs are conducted to include health resource of the community, not the hospitals alone. We have to ensure that the curriculum content reflects national health programs. We have to establish examination system and curriculum to ensure the achievement of professional competence and social values, not merely retention of the information. We have to encourage opportunity for joint learning research and service with other health and allied professions as a part of teamwork training. Now, the consortium approach in which each stakeholder contributes to the ideas, why we cannot discuss or why we can give an idea one day in advance, okay, come prepared, tomorrow we are going to discuss, and what could be the problem, what are the solutions, and what can be, we can come out. Then blog posting is another way of, an effective way of community-based learning is a blog posting of the students. Then integrate social responsibility into the medical education. I took over as HOD about 5 years back. We introduced the, in the morning ILM, that is the integrated learning modules. And 12 to 1 is the problem-based learning, means the residents, they go for the ward rounds, come back at 12, whole faculty and residents sit together, discuss the problem, and then they discuss how this problem could have been solved. And evening we have a leadership forum and so many journal club and other things. What I observed in 5 years, so this has paid to us. So that students are not actually trained in one particular area, so they are in different allied subjects there also. And we are getting faculty on every week. Every Saturday we have a faculty from other sector, from private sector, from the banking, from ministry and so many other organizations, to invite them to share, but related to the health sector. Now there are few skills that curriculum should address. The management skills. You must have seen that in our country, our doctors, senior doctors, they take the management positions by virtue of their seniority without being subjected to any training program. So there is a need for, if anybody is going to take over that position in the hierarchy, they must be subjected to some management development program. The communication and public relations skill, very important. Today morning we had a discussion with the director and DDA, how we can start the communication workshops on behavioral aptitude, sort of to all category of people. So this decision we took today morning, that in coming 3 months, we want to cover whole of the staff, which is about 13,000 people. Then soft skills, like IT skills and e-labs, vision sharing by experts, then orientation to nation's health system and policies, professional skills, ethics and human values. There are so many issues, ethical dilemmas are there, organ transplantation is there, but our students are not prepared to that actually. What are the implications of CPA? What are the implications of right to information? So they need to be updated on these issues also. So whatever we are teaching, we must preach that also. Now then allied stream integration like behavioral sciences, the social work, the health economics, personality, human development, the patient safety, quality and patient safety is very important as on today. When a patient visits to the hospital, he will ask, is your hospital safe? What are the system in place that I don't get any harm? What are the systems? There is no wrong surgery. No wrong patient is operated. So these are issues which are being debated, and the patient, the so-called customer, is very aware about his rights and he is going to ask. Then what is the system of de-stressing? Because I have done a study in my department, what I found that my faculty is putting 30 to 33% extra personal time in the hospital. Their family time, their extra time, whether it is on routine working day or Saturday and Sundays. So if 30% extra time they are putting, they have to have a stress. They are dealing with different situations. How to manage a death in the ward, that is itself is a challenge. Then understanding the concepts of death and dying, actually, they must, at this situation, how to react that actually. The patient safety concept to be included in undergraduate and postgraduate curriculum to inculcate patient safety culture in healthcare practices, need for patient safety policy in the country, need for patient safety bill, or need for a national program for patient safety. And I am happy to share that we initiated a national initiative for patient safety program. No, government has already acted at, and the proposal is with the Planning Commission. And we are sure that this national program for patient safety is going to be launched soon in our country. Now the question is reforming curriculum enough? There is a need for faculty development, which is an essential part of reforming curriculum. Students learn what a teacher practices and not just what the teacher teaches. So faculty capacity building is a low-cost investment. Now sometimes the issue is whether I should my faculty, Hopkins, Harvard, spending hundreds of thousands of dollars for training few faculties, or I can invite them, pay the resource faculty, and have training of maximum number of people. So these issues needs to be discussed. But there is a mismatch between the taught and sought. So there is a need for 3-degree assessment at all levels in multiple occasions during using the multiple tools. So aptitude of would-be graduates is never examined, whether they have got a aptitude for the medicine. And the need list is in disharmony with the wish list. I think these are the issues which needs to be debated actually. And then the question comes how to fill up the gap when a large number of medical colleges are coming, large number of aims like institutions, but how to fill up the gap, that is a human resource. When we say there is shortage of doctors on one side, from where you are going to get the faculty. So existing faculty, these are the discussion which we had in our department, and we have come out with some of the things which I want to share with you. Existing faculty in various private hospitals can be trained in teaching some of the institutions, and their services can be utilized for teaching in various medical colleges across the country. They can have dual designation. The consultant in their respective hospitals and the teaching designation as per their length of service. They can be designated as assistant professor, so that their services can be utilized in teaching, and they have an excellent exposure. Doctors from clinical specialty can be utilized for teaching non-clinical and paraclinical subjects, because problem will be with the non-clinical and paraclinical subjects. This is going to be a problem. We cannot start any medical college unless we have faculty in these two specialties. A medical college should adopt at least 3 district hospitals, and these doctors should be trained. Why can't a medical college adopt 2-3 district hospitals, and whatever resources are there, we should train them in teaching for 3 months, 6 months, whatever is required, so that the students, when they are posted in the district hospitals, so teaching can be done in the OPD itself, in the ward itself, and we can use so many district hospitals in our country. A medical college should adopt at least, then district hospital to be upgraded in terms of infrastructure with latest technology, and doctors should be trained. Services of the retired medical professionals, including army doctors, can be utilized for teaching purpose. The retirement age in our government medical college is 58 years. No? It is different that, okay, we have got about 65 years. Why they can't be utilized till 70 years? Maybe after retirement, they can be utilized for the teaching purpose, giving them appropriate teaching designation. Now, visiting faculty from various public and private hospitals on payment basis, maybe some honorarium can be given. Of course, if they are spending 1 hour, 2 hours in teaching, they must be compensated. Doctors with 2 valid PG degrees to be utilized for teaching in both the specialties. Utilization of faculty from the same institute as an adjunct faculty in other specialties also. And same faculty can be utilized at other medical colleges after they complete their schedule of education, teaching and working hours, so that their talent is optimally utilized. I have seen in US Shakti that our faculty, they work for 40 hours in the hospital. Once they finish their 40 hours, they are allowed to do teaching in other institutions and hospitals. So why can't we do also that actually? Use of telemedicine to conduct lectures, virtual teaching in various network medical colleges, and we are already working. Dr. Manoj Singh is almost going to implement this virtual teaching with all medical colleges in our country. Now the solutions, the content of the training programs or curriculum need to be changed in consonance with our changing needs. We need not to actually repeat that which is there for last 20 years, 30 years. I think every 5 years the curriculum needs to be updated. Need to initiate new PG disciplines. Why can't we introduce the faculty of emergency medicine, the family medicine, or the geriatric medicine? So that more opportunity for post-graduation courses are there. Creating a conducive environment to encourage reverse brain drain. That is the need of the hour. People in the other countries very keen after working for 20, 30 years, they want to come back, but we need to facilitate that. There are some examples, they have come back, but they have not after having a bitter experience over here. Then developing center for excellence for clinical and scientific research to make the country lucrative for skilled professionals, because some people are motivated and by financial incentives, some people are motivated because of the environment for research and development. So accordingly, the requirement of the faculty, we have to create an environment. Now we have to ensure adequate emoluments which medical professions deserve. The remuneration would be comparable to the competitive career, considering the long duration and rigorous training programs. Now to conclude, the high standards of teaching are to be maintained. Nobody can compromise on that. And improved upon with constant seminars, some workshops, some research work, some training program which should be made mandatory. Why not we can make a mandatory orientation program for each and every doctor, nurse, or paramedical staff who are working across the country. Teaching aids, computers and other IT can be used. Private sector has to contribute to the medical education in a big way and more responsibly. I think this is the talent which is hidden, which we are not able to exploit. I think this is a time when we must involve them. Why can't a doctor, senior doctor from the Medicity or Max or Apollo can be utilized in All India Institute of Medical Sciences and other similar institutions? So I think if we give them some incentive, it will give them a satisfaction also, because they are teaching designation and they have a general consultant also. The use of information technology to reach inaccessible areas, and government has to come up with innovative plans and proposals for human resources for health, apart from increasing expenditure toward the medical education. Thank you so much. Thank you.